Ladies and gentlemen, welcome to the beginning of our meeting, of our scientific program. I can think of no better person to start us off than Andrew Moore. He really works in the spirit of Ulf Lindblom, who this meeting would not exist without Ulf. And I think the theme of this meeting is very much, would have been very important to the way that he thought about pain science. And it gives me terrific pleasure to introduce my friend and colleague, Andrew Moore, to you today. Andrew's been working in pain and biomedical science for over 40 years. Let me give you some of his remarkable statistics. He has published over, 600 scientific papers. 200 of those are systematic reviews, and if that is not remarkable enough, and I think he deserves a special medal for this, 100 of them are Cochrane systematic reviews. Not one, not two, but 100. What Andrew has done is really systematically, consistently taken a long view of what's important in evidence and pain science. He hasn't wavered by fashion. He hasn't given in to momentary sparkle of something that's interesting. He has held a strong course on what the important views of evidence are. In some ways, what's nice about having worked with Andrew for some time is understanding that he is both a gentleman scientist, but he's also a modern intellectual, somebody who really understands the context in which we are trying to make pain science better, consistently challenging us to do better. So I want to pass over the stage and let's open with some challenge. And I give you my friend and colleague, Professor Andrew Moore.
Well, thank you, Chris. I like the idea of having some sparkle. 8:30 in the morning, 7:30 in the UK. Having a bit of sparkle would be really just terrific. It's a great honor and a privilege to be here to open your meeting and also to speak in the name, as it were, of Ulf Lindblom. Henry McQuay and myself went to Huddinge in the early 80s. For several days of intensive, vigorous and robust discussions about whatever it was we were talking about at the time. And I have to say, I have forgotten exactly what it was now, but the interesting thing about it was that I took away from it was the absolutely wonderful tidiness of all of those Scandinavian offices. And I thought that's something I must aspire to, and I've never achieved. When Chris asked me to do this, I thought, well, what am I going to talk about? And I thought, well, I can just reiterate some of the things that we've been doing over the last 20 years or so. But actually, I thought it might be much more interesting to take a look forward as to where we've got to go in the future with evidence, because I think we might be at a bit of a turning point. So I chose this title about what makes evidence useful for everyday use. And then it's, of course, whose everyday use? Now, I'm very lucky. I go to various parts of the world where people ask me to talk about evidence and pain, and very often they lie through their teeth. They come along and say, it was a great talk, Andrew. But then they always say, but. And there's a but. And I want to explain the but to you in terms of a very short story. It's a story about a general practitioner who sends a patient with a peripheral neuropathy to see a consultant in pain, a very good consultant in pain. And the consultant in pain says, I think you should have treatment A. Letter comes back from the GP which says, treatment A can't be done. It's blacklisted. So patient comes back again. Consultant says, well, you tried everything else. Treatment A is the thing, and writes that to the GP. And the GP says, we can't do that. Then there is a hiatus where the patient does not appear at the consultant's door. But eventually, 6 months later, he does. This time, he comes along with an amputation for his peripheral neuropathy, and other problems, as well as the peripheral neuropathy, and the consultant's decision is actually, I think you should have treatment A. And it's that idea that behind the decisions that we might want to make about individual patients are other people who are determining what we may or may not use. And I know that this might be a bigger problem in, say, the United Kingdom than in Germany or in Austria or other countries, but right around the globe one sees some form of problem. So if I'm going to make my evidence useful, is it going to be for the everyday consultation? Well, I'm an academic, and obviously impact factors are important, so am I going to just produce evidence for all the clever academic docs out there which might want to use it in some way or another? Or perhaps should we be making evidence more useful for people who sit around a table and make medicines management decisions or formulary decisions, which has so much of an impact on what doctors and other clinicians can and cannot do, and on patients' lives. Let's step back a moment and think about what the fundamental principles, the founding principles of evidence-based medicine are all about. Back in 1996, David Sackett, a wonderful, wonderful Canadian-American who came to Oxford as a professor of evidence-based medicine, said he died this year. It's a great loss. They defined evidence-based medicine, as you will see many times, I know, about the being the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. That bit is often forgotten. But this, as it were, was putting a lid on an argument that had been boiling in Oxford and elsewhere for some time. Best articulated here by John Grimley Evans, a professor of gerontology, who said that managers and trialists may be happy for treatments to work on average. Patients expect their doctors to do better than that. And even before that, in the pain unit and in the evidence-based medicine department, where we interacted a lot, we had come to the conclusion that there are limits to evidence. There are places where evidence can go and no further. So, to put it very simply, there's a massive information out there in terms of single papers, randomized controlled trials, and that what we do when we're doing systematic reviews and meta-analysis is distill that down to integrate perhaps different types. Most importantly, to look at quality standards so that we're giving you good, robust knowledge. But the way in which that knowledge is used when a clinician is looking at an individual patient is, of course, very different. There's what the patient wants, the condition of the patient, the conditions you're working in, and everybody's values. And decisions that are being made there is not something I can do, but that was the worry always, that evidence would be used beyond where it should normally go. There are, particularly these days, because EBM has matured over the past 20 years, some wonderful examples of evidence and how one might want to use it. None better than the NERPSIG guidance for neuropathic pain, championed by Nana and Nadine recently. And I've put my colors on this, Nana, so I hope you don't mind, but what it's telling you is that there's very strong evidence that we should use some things, maybe some weaker evidence for some others, maybe strong evidence against some others, and a whole range in the middle where things are inconclusive. And we and others have always tried to look at the clinical perspective when we're producing evidence and come up with results and interpretations that make sense. And, you know, I'm indebted to people like Aya and Andrew Rice and Dominic and Peter Coles in our department now, and Henry beforehand, because we always try to work very closely with the clinical world. And we felt that, certainly I feel that this is one of the best ways in which you can present evidence for, you know, sensible use today. But it is being blocked. And one of the drugs that is a weak for was the drug A in the story that I just told you. That is, we were stopped from using evidence. Now, in the past, I have railed against formulary committees, and I think it's possibly time to stop doing that and ask, well, how can we work with them? Because they're not stupid. They have many challenges, and they even sit down and think, well, how can we define the principles for evidence-based formulary or medical management. And there is much that one would agree with. For example, that experimental data should take precedence, that morbidity and mortality outcomes, again, should take precedence over surrogate measures, that when we look at claims for advantages, we look across the whole range of treatments, not just those very narrow comparisons, perhaps that pharma very often make us want to look at. But then there are things that, well, they grate a little bit. That is, they say you can only take variation between individuals into account if those differences are predictable. And we know that in chronic pain that's difficult. It might not be impossible, but difficult. And then they say, well, also, that argues against changing treatments. And that does grate. But again, to be fair, they recognize the difficulties. And there's a really interesting conversation that the authors of this paper are having with one another, which essentially is saying, look, equal on average is not equal for everyone. They recognize this. They say, drugs almost always have got some inequalities about the way they work in different people. You could use this to say we should have a very wide formulary or a very, very narrow formulary, and that both of those are wrong. And it all hinges on prediction. And there's some at the bottom there says, well, equal efficacy on average does not imply that equal efficacy for individual patients, but that the use of a more expensive medication is often justified for those responding poorly to first-line treatments. That's a very sensible idea. But it's all about issues of prediction. And then there are other people, perhaps, that we have, in the world of evidence, failed to some extent. And those are people who are trying to sit back and say, well, look, let's look at the care of people with chronic neuropathic pain in primary care as a whole. Let's take a holistic view. And here's a group in Canada, it's a very recent paper, who tried to do this. They recognized that their pain treatments were not doing all of their patients as well as they might, and they wanted to prioritize what they could do to make it better. They got together whole groups of people, doctors, nurses, pharmacists, physiotherapists, and patients themselves, ran a whole series of workshops and focus groups, and came up with a series of answers. And they make you want to weep, really, in the sense that what they're saying is that there's an enormous knowledge gap. For example, that extends down to the idea of measuring pain. And this, again, is something that is not uncommon, where people say, how do you measure pain? Which measurement scale is best? Come on, give us a break. We've known for years and years that it doesn't make much difference. But they just don't have that knowledge. There's this incredible lack of awareness about chronic non-cancer pain in the community. That is, not believing that it is a real problem, not believing that the pain is genuine, not believing that that chronic pain is ruining people's lives. And so therefore it's not important. That's an easy way of doing it. And also from patient perspectives, thinking that they need empowerment, they're isolated. I'm not telling you anything new here, but at least these people are looking to see what it is that they want. Now, it's a somewhat different agenda from what our formulary committees are asking for, but the two are very much linked. So how can evidence help? Well, it can help. I think this is important. I'll tell you what I think. I think it can help define outcomes for clinical trials and clinical practice that are of real value and of general utility. And that is an important thing to say. It has to examine the nature and consistency of response to treatment. It can help define futility or stopping rules so that treatments that don't work are discontinued. That's a real worry for pharmacists, people on formulary committees. That overwhelmingly drives some of their concerns. We can provide evidence for the utility or benefits of switching strategies. An important thing to say, well, if something's not working, what happens if you change? And in a slightly more nebulous way, we can help formulary committees to understand the need for a degree of elasticity in what they're doing. So I'm going to try and work through those one after the other, relatively briefly. What's an outcome? it's not a measurement of pain. So often one reads in systematic reviews, meta-analyses, randomized controlled trials, that the outcome is a pain measurement. And it's not, it's something else. It's a result, a consequence, a verdict. To give you an example, I am Welsh, and I'm being followed by Ralph Barron, who is German. And if Wales were playing Germany at football, the outcome, Ralph, the desired outcome, is that Wales win. You might see things differently. The playing of football is really rather interesting, but that's not the outcome. So looking at things in a different way, rather than just saying we're going to measure pain, we want people to have a degree of pain relief that is beneficial. And if you ask patients, that's what you get. This is a systematic review of asking patients what they expect from treatment. And if you say to them, what do you want? They say they want their pain gone. When do you want it? Now. And what people in pain want is no worse than mild pain. Not moderate pain, not severe pain. That's what they want. But they want more. Typically, they will say that a reduction in pain intensity of between 50 and 70% is what they would call treatment success. Not 10%, not a 10 millimeter change on average, 50 to 70%. And their desired level of pain relief is below 3 out of 10. But in addition to that, they want large reductions in fatigue, in distress, and the interferences with daily living that come with having chronic pain. And one of the things that I think we can do, again, there's loads of evidence out there that getting good pain relief improves whole aspects of life. Here's an example, for example, from fibromyalgia. Here are just under 2,000 people who completed some very large and long randomized controlled trials. And at the end of the trial, what we did here in an individual patient analysis was to say, for those who had a patient global impression of change score, what was their pain score at that particular time? And you can see that in blue there were those who said they were much or very much improved, and they're on the left-hand side, which is where the pain is, generally speaking, below 3 or 4 out of 10. On the right-hand side are those in red or in yellow, where there is no change or indeed pain is worsening. And again, there's a pile of evidence which links improvements in pain with improvements in quality of life and in function and in work. Here are two looking at short form 36. On the left-hand side, migraine, people with frequent migraines, where in red you're looking at those with a more than 50% reduction in migraine frequency, and in blue, those with less. And in fibromyalgia, those with more than 50% pain relief over the extent of the trial, and those with no benefit. And you can see here that for all of the 8 domains of the short form 36, that is general health, physical functioning, physical and emotional roles, social functioning, mental health, bodily pain, and vitality, you're tending to get very large increases in quality of life. And as I said, and just to repeat it, you get exactly the same thing in terms of work, in work interference, in sleep, fatigue, a range of things. And just to emphasize again, those thoughts are embodied in systematic reviews that we have done, which could be done again and could be expanded and looked at in different ways. So we can at least begin to think that we are responding in part to what it is that people want. And this sort of information is indeed very useful. However, there are areas which are still open for to criticism, and particularly the idea of what a response is. Everything we've said has been predicated on response, but Bob Dworkin and Stephen Sen made some sensible comments about this in Pain last year. They said that we recognize there's individual differences in terms of response to treatment, but there may well be measurement and other errors contributing to what we call a response. They also went on to say there's no replicated examples of successful prediction of response, which may or may not be true. So our response to their attitude to response is that what we have to do is to explore the nature of response and its consistency as much as we're able. We've not just got to leave that and put it on one side. So what I'm going to do is to show you some data now in a series of slides, data from individual patients. Each patient in these graphs is a single line. In each of them, we take a very conservative attitude that if a patient remedicates in acute pain or withdraws in chronic pain, we give them the pain intensity that they started with. And that's whatever cause of withdrawal that is there. And I'm going to give you a set of examples in acute pain and then a set of examples in chronic pain. So, as you know, single-dose analgesics are tested very often in the third molar extraction model, where people, after they've had 1 or 2 or 3, sometimes 4 third molars extracted, wait until they've got moderate or severe pain and then are given a tablet. Now, what you're looking at here is that there's pain intensity from 0 to 100 over 6 hours, 360 minutes. Each line is a patient. And you can see that they're starting out with very high pain intensities between 60 and 80, and in very many, given placebo in this particular case, the pain goes up. In some, the pain comes down. And in some, they are remedicating at 90 or 120 minutes, at which point we give them the pain intensity they had at the beginning, which continues for the rest of the study, which explains all those parallel lines going across. But by and large, I think we'd agree that placebo is not providing very good pain relief for many patients. Most of them are not having good pain relief, and that continues. It's consistent. If we give them a gram of paracetamol, then lo and behold, actually a number of them now are having rapid pain intensity reduction in the first hour or so, and for many it lasts longer, but for many also the response is limited in time, and so they're remedicating a little later, between 2 and 3 hours. But if we give them a really good postoperative analgesic, this is a fast-acting formulation of ibuprofen, 400 milligrams, you can see that nearly every patient is having a rapid reduction in pain intensity over the first hour or so, and then for almost all of them that is continuing over the rest of the period. So what we're seeing in this acute pain system is that we're getting consistency. People are either getting a response early or they're not getting one at all. If they get a response, it tends to carry on for most of the study. Now, in chronic pain, we see the same thing. Again, looking at individual patients. In this case, fibromyalgia, where we're looking at pain intensity, again on a VAS-PI scale, at 0, at 5, and 9, and 13 weeks. These are people who have had more than 50% pain intensity reduction over the period of the study. And you can see these people are responding early, at least by 5 weeks, and then largely most of them are continuing for the rest of the period. Some are a bit slow in responding, a few have some excursions above 4 out of 10, but most of them are below 4 out of 10. They've got no worse than mild pain at the end of the study. Let's look at a group of people who were not responders, those people who had less than 15% pain intensity reduction. And by and large, most of them never had any pain relief at all, and apart from a few who had some initial pain intensity, then probably withdrew, mainly because of adverse events. And then there is a much smaller group then in the middle, and for these, you'll see that there are almost no withdrawals. I don't think it's a single withdrawal there. That overall, what we're seeing is that the pain intensity is drifting down, but that the pain intensity at the end of the trial is somewhere between 4 and 40 or 80 out of 100 millimeters. And it's a much more mixed pattern. It's a much more difficult and nuanced area to look at. So putting that together and adding in a whole series of other bits of information that I know about, which I'm not showing you at the moment, what I think we can say is this, that in acute and chronic pain, response is consistent. Responders respond early and generally continue with much the same response over time. Non-responders tend not to respond at any time. In other words, we're answering the sorts of questions about error that Dworkin and Sen were raising, and it's important that we have done that. But we can go further. I think we can go further to use these sorts of observations, at least ask whether we can, to provide stopping rules, so that if somebody is not responding by a certain time, we can say you don't have to keep on taking the medicine. Now, Using these fibromyalgia data that I've just shown you, this is what you see. It's a typical bimodal distribution where some people are getting large amounts of pain relief, those on the right. A lot of people are getting no pain relief, those on the left. And don't forget, this is fibromyalgia. And it's these on the right-hand side, the responders, who we want to hopefully identify because these are the ones who are going to have the long-term benefits. And the ones on the left, really we want to stop treatment as early as possible because for them there's unlikely to be any long-term benefit at all. So can we create a stopping rule? I think indeed we can. A stopping rule is a point where we can be pretty sure that further treatment is futile. And a stopping point is reached in a number of ways. The simplest one is when patients say, I don't want to take that medicine any longer, either because it's not working, or because they've got an adverse event, or for some other reason. But also when there's an inadequate level of pain relief to justify further treatment in the knowledge that further treatment will not bring good pain relief. That is the nightmare scenario of the formulary committees is when people are taking vast amounts of medicine which cost a lot of money but which frankly are not working and putting them at risk. Here in fibromyalgia, using the data I've just shown you, what you can say is that people who were non-responders at 5 weeks, that is they had less than 30% pain intensity reduction at 5 weeks, were overwhelmingly patients who had less than 50%, less than 30% pain intensity reduction at the end of the trial at 13 weeks, 90% of them. And so what we can say is that stopping treatment prevents treatment when there are risks and costs, but when there's no benefit, and we have a stopping rule. And again, this stopping rule, which is here for fibromyalgia, seems to be one that we're replicating in other areas. And later in the week, tomorrow, I'll probably be speaking about some other examples just like this. But I just want to make the point that it isn't just here in fibromyalgia. There are other bits of evidence in the literature which we should be pulling together. I'm going to give you a couple of examples. The first, well, both of them in osteoarthritis, but the first comes from some work that was done by Chris Bingham some years ago now, where they combined 1,200 patients in 2 randomized controlled trials of osteoarthritis in the hip and the knee, and they were using the Omaract-Oasi definition of response. I'm not necessarily convinced it's the best one because it's a combination response, and that has some problems with it, I think. And then here in this graph, what they're doing is combining response and non-response. And what they're saying is that this is largely established by 2 weeks. You can get somewhat better results at 4 or 6 weeks, but it's largely established by 2 weeks. And even more data in osteoarthritis comes from this large systematic review and meta-analysis in osteoarthritis that I've been involved with, where we looked at individual treatment arms where there were data at 2 weeks, 6 weeks, and 12 weeks. And what one can see, I'm showing you the data here comparing 2 weeks. CFB has changed from baseline, so we're looking at change from baseline in terms of millimeters at 2 weeks and at 12 weeks, and you see they're virtually the same. And you see the correlation coefficient here, this is an R squared. It has got a value of about 0.8. And if I showed you the 6-week data, the R-square value goes up to about 0.95. So if you don't want to, if you think 2 weeks is too short, and you want to go to 6 weeks in osteoarthritis with NSAIDs and other treatments, you can get there. And you know that if you're not getting a response, you don't need to continue. Nor, by the way, is this something that is confined to pain. It's not. There's a guy called Nicholas Christakis. He's the professor of medical sociology. Don't know what that is. Medical sociology at Harvard. I do know what that is. And he had a lovely paper in the BMJ some years ago, and I'm going to quote from him. My point is, he said, that drugs is not the drugs evaluated in randomized controlled treatments are not terrific. They are. And the scientific evidence for their efficacy is impressive. Rather, the problem is that patients and doctors lose sight of what the trials actually show, namely that the drug may have no effect whatsoever in any one person, and hence fail to consider the need to switch or stop taking the drug. And that attention to variation in a patient's responses, that's essential for any drug that does not affect nearly 100% of patients. And as far as I know, that's almost all of the drugs that we use in pain. Nor is it just pain. Because what Christakis and others have pointed out is that it's across the board. So, for example, blood pressure measurements with antihypertension. I mean, most people who start on antihypertensive after a few months are on another one. Cholesterol measurements with statins, tumor markers, or imaging in cancer, response or non-response in erectile dysfunction. And wherever you go, you're getting this same situation that some people are doing well and some people are doing badly, and that you measure some sort of outcome, and if you don't get the outcome that you want, you stop treatment and you switch. And in a very recent paper here in CNS Drugs, talking about antidepressants, they're saying there's no indication of early improvement at 2 to 4 weeks after starting an antidepressant, and taking into account, obviously, other patient and clinical factors, a change in management can be considered. And that change in management when it comes to pain is something that we have to consider a lot, because as you well know, when you go out and look at people with chronic pain or people in hospital, what we recognize year after year, study after study, is that it's poorly treated, generally speaking. Here's an example from Osteoarthritis in Europe, from Phil Conahan in Leeds, looking at 1,000 European patients well looked after by specialists or GP on treatment for osteoarthritis. Half of them have inadequate pain relief. They have moderate or severe pain on treatment. And so the argument would be that they should be switched to another treatment. Now, there are actually data which tell us what happens when we do switch and the benefits that patients get over and above pain. I'm going to give you 2 examples, one from osteoarthritis and one from neuropathic pain. The osteoarthritis example comes from Taiwan, where over 500 patients were on treatment, as in that last slide, with various treatments, and had moderate or severe pain. Their average pain was 5 out of 10. It would get them into a chronic pain trial. And they were switched, because this was an MSD study, all of them to 60 milligrams a day of etoricoxib. And what was interesting was that of these, 29% had a pain intensity reduction of more than 50%, and half had their pain reduced to 3 out of 10 or below. And not only that, but those people who had their pain reduced, as you can see there with various levels of pain relief or with a low PI, had big improvements in their WOMAC physical function following that pain relief. And not only the WOMAC physical function, just focusing here on those with more than 50% pain intensity reduction in their short form 36 mental and physical subscales, they improved dramatically. And in terms of the various responses on the BPI interference scale, in terms of enjoyment, in sleep, in relationships, in normal work, in walking ability, in mood and general activity. And those improvements were found in those people who had the good pain response and not in those who didn't. So that sort of result is giving us exactly what we know in other circumstances. So switching can be really beneficial. In painful diabetic neuropathy and neuropathic pain, there's only one example that I've found so far. It's a retrospective analysis of a subgroup of patients from a very large neuropathic pain study of switching. And it involved 100 individuals with inadequate pain relief on gabapentin, a reasonably dose of gabapentin, who were switched to pregabalin. And these people had a pain intensity of 68 out of 100, so they had a really moderate to severe pain on gabapentin. When they were switched and followed for 12 weeks, half of them had more than 50% pain intensity reduction, showing that switching of treatments can benefit a significant proportion of patients, probably as much as you get if these people were treated de novo. Now, you all know that pregabalin is more expensive than gabapentin, and so the drug cost, the average drug cost per patient, rose by 113 euros. But the healthcare costs fell by 350 euros. So for every euro you spent on the drug, you got 3 euros back. You were saving. and the overall cost fell by €1,000 per patient. There were fewer working days lost, and there was a 20% increase in work productivity. Now that's a real win. So that's important. Now, can we then step back from this and say, can we help our friends in the formularies and medicine management committees develop some rules which are useful to us and our patients? Well, I think it's very difficult at the moment, and I'm aware that Ralph is looking at me from the front row here. I don't think at the moment we have any general, simple rule which tells us which patient with pain responds to which drug. We're moving towards it, it's a dynamic, and I'm sure we will get there. But right now we don't have it. But we can know quite quickly which patients are not responding and who might benefit from switching to another strategy or stopping altogether. Which leaves a question of how many drugs we need on a formulary to treat the whole population of people with a condition. So here I'm moving back from the individual to a population of people with a condition. So let's look at the idea of success and failure. Some work that Chris and Aya and Sheena Derry and I did a few years ago examined the concept of failure, the idea that we failed to produce the outcomes that patients want and the outcomes that produce good economic benefits. And we had tables, I put them in figures here. We looked at Cochrane reviews, and here we're looking at painful diabetic neuropathy with an outcome of at least 50% pain intensity reduction after about 3 months or so of treatment, with duloxetine, pregabalin, gabapentin, glucosamide, and pregabalin, and some of these you might not use for other reasons. But the point is that our success rates were somewhere between about 15 and 30%. And if you go to post-herpetic neuralgia, again, our success rates are somewhere between about 15 and 30%. And if you go to fibromyalgia, our success rates are somewhere around 10 to 15%. They're not very good at all. But, you know, as everybody says to me, or certainly people who treat fibromyalgia, when you get that outcome, it is fantastic. It is life-changing for the patients who get that success. It's an important success. And in osteoarthritis, again, we're in that range of 15 to 30%. So the best evidence we have comes from systematic reviews of high-quality randomized controlled trials for drug treatments. We can be reasonably confident that patients achieving more than 50% pain intensity reduction are likely to benefit in terms of quality of life and function, and they'll have low pain. In chronic non-cancer pain, the proportion of patients who achieve long-term response is at best modest. But it's generally the same between groups of treatments that we have in any particular condition. There isn't an example that I know of yet where one drug absolutely outshines all the others and is providing very, very high success rates. So what we're looking at in all of these pain conditions is something like a 10 to 30% success rate and a failure rate of 70 to 90%. Now, I don't know whether you've noticed, but I've got almost to the end of my talk, and I have not yet mentioned an NNT. I regard this as a minor triumph. Actually, no, I actually think of it as a major triumph. I think this is an important thing to do because things like statistical outputs, even NNTs, can be barriers to understanding, and trying to avoid them may be something that we need to do. Important for us pointy-headed academics and whizzo docs, but you know, maybe for the real world we need to put things in a different context, which is what I've tried to do. So thinking about what I want to do for my friends, if I may put them like that, in formulary committees or medicine management committees, I want to provide them with some thinking that will help them with their elasticity and give them an idea of how many drugs they need on their formulary to be effective in treating a population. So no NNT, but I want to introduce you to this idea of a NOF. That is the number needed on formulary. How many drugs do we need on a formulary to treat the whole population of people with chronic pain. Well, if your typical success rate for treatments is around 30%, then you need a minimum of four to do that, and possibly more than that. But if, as with fibromyalgia, possibly chronic low back pain, typical success rates are lower than that, you might need a much larger number. And as a general rule, if you know the typical NNT for a particular condition, then the NOF is the typical NNT plus 1. It's a work in progress, but we think it might be useful. As I set out at the beginning, I thought there's a gap. It's a gap that evidence so far has failed to fill. But I think we can fill it. I hope what I've done is to give you some insight as to the way that evidence might develop to make it more relevant and useful to people, and particularly those people who make decisions about how we can treat it and bridge that important knowledge gap. And if we can do that for them, then frankly it's going to be more useful for patients, it's going to be more useful for clinicians of all sorts, it's going to be more useful for patients or journalists or anybody who wants to look at things. But I think trying to look at evidence in this way comes about with a few problems. If I might just take a minute to specify what those are. First of all, we've been doing this now for about 20 years. Some of us have been doing it a bit longer than that. And the reality is, I think we've matured. What we've got is something that works very well. We understand it. We have discovered many biases. And to be honest with you, I cannot at the moment see that there are any new biases that are going to come out and bite us. And yes, we can carry on doing Cochrane reviews of interventions for pain, but we're not going to learn much more than we know at the moment. And I don't think evidence is going to change all that. So what we've done, while it's not coming to a grinding halt, and it needs topping up and improving and polishing and so on, it's where we are. We need to change to look at other forms of evidence, particularly about things like drug safety, about the economics and so on, and bring that out. But there are problems here. I promise you, this is not something that, I'm sorry, Chris, I don't think this is something that Cochrane can handle, not in its current format at any rate. So, these are quite difficult things to do, not overwhelmingly different, but quite difficult things to do. There's a problem as well with publishing, because whereas, the Cochrane collaboration, Chris's PAPAS group has got an impact factor of 7, which is fantastic. So you got a Cochrane review published there, you're doing very well. But the sorts of information that we're looking at here and the sorts of reviews that I'm suggesting that we might do are not really welcomed by journal editors. And so they tend to be published in journals with much lower impact factors. And for those of us who are academics, that's an important thing. And the question then is, well, who's going to back this sort of work? I promise you, because we've trying to get financing for this is difficult sometimes. The industry will step up to the mark, not often. There is another gap, and it's a gap that I think can be filled possibly by organizations like ETHIC and IASP, who recognize that we need to make a change, that recognize that we need to do things differently, which have got SIGs with interested and interesting and thoughtful people who can do some of that. And that would be a really interesting challenge for the future. And it would make things very interesting and I hope very useful. So, thank you for listening.